NVN Reddy garu to enlighten us about the instruments and pathology specimens.
Of these instruments, specimens, followed by operative surgery. Just we are going to give a glimpse how we are going to operate. Obviously, it is not possible to complete, one by one all the instruments. There are so many, hundreds of instruments we cannot complete. Just to give us a short glimpse how we are going to approach, followed by the specimens, how we are going to approach. We will give some examples.
Exactly in a situation where we have our afternoon session.
Excuse me, sir. Can I request Dr. Lakshman sir?
Yeah.
Please come, sir. Dr. Murthy sir, Lakshman Murthy sir.
Yeah.
Please come, sir. Please come. Come, sir.
Prepare to take your afternoon Viva session. And most of you know your fate will be decided in the morning, and we had some good examiners who were very generous enough actually to pass most of you. That's what I expect, that you have passed all the postgraduates who have presented. And so what I just would like you to take seriously is this is a session where you can score the maximum marks. So we have about 100 marks here, and you all know that these marks are going to be added to your theory, and you all know the importance of these theory marks. So as Dr. Kota was trying to tell, that it's very difficult to cover surgical instruments within a short span of probably, but I would like to do some justice. I'll try to bring in some overview of these particular instruments, and maybe if not 15 minutes, I might take 20 minutes, and the rest 10 minutes I would like to spend talking on specimens. So the basic surgical instruments I would like to probably deal for 6 minutes, and tubes 4 minutes, and the laparoscopic instruments 5 minutes. And what I just would like you to probably take back home is, most of the times the examiners are so liberal that they give you a choice to pick up an instrument. So whenever you are given that chance of picking up an instrument, try to select something which is very easy and where you feel confident to answer that. Don't try to pick up something which is very difficult and land up in problems. So try to pick up something which is very easy. And sometimes it so happens that they just keep the tubes and the instruments on the table, and then you need to just identify one by one. So it's so simple. They don't even ask you like how do you identify this instrument, and what are the exact usage of these particular instruments or tubes. So take this as an opportunity to score more marks, and this is how we basically, these are the terms which we often come across: traumatic, atraumatic dissection, dilatation, grasping, retraction, and trocas. When I look at the basic surgical instruments, why I just would probably have your attention on this slide is most of the surgical instruments have a similar parts, so it's not necessary that you need to probably look into this. We will identify an instrument with difficulty, because as you know that if you take a simple instrument like this, a Specimens curved artery forceps, obviously we have what is called as a finger post, and this is called as a ratchet, and this is a handle, and this is a joint or the lever, and these are the blades, and this is the jaw, which is probably here conical and rounded. General trend of examiners would be where they would not spend much time on this, is they would like to probably ask you like what are the instruments without a ratchet, and what are the instruments where you don't have these finger bows, and so try to probably have an open mind when you're answering these instruments, particularly when you, very common question is what are those instruments where you don't have a ratchet. So any answer? The most important is the sinus forceps. I believe that if I am an examiner, I would probably pick up sinus forceps and expect the student to answer. Why I just pick up a sinus forceps is because where do you would like to use the sinus forceps? So abscess drainage. So what I try to probably do is, I'll ask him, how do you do it?
How many of them have seen sinus forceps?
I'm sure that at least most of you have seen the sinus forceps. Am I right? So what is the sinus forceps called? Is there a name for the sinus forceps? It's called as a Lister's, very good. Lister's sinus forceps, and though it's being used for drainage of an abscess, but why do you think it's being called as or named as a sinus forceps? Because most of the instruments probably might have been devised for some other purpose and it's being used for different purpose. As the name suggests, it's called as a sinus forceps. Why is it called as a sinus forceps? So you all know that osteomyelitic sinus is something which is very common, and we need to probe this osteomyelitic sinus. If you remember that we need to remove that sequestrum and then pack the sinus cavity with antibiotic impregnated. So this was the reason why this particular sinus forceps was designed. So that's one instrument without a ratchet. Can you name some other instruments where you don't find a ratchet? So all these stone holding forceps, you start from Desjardins or cystolithotomy forceps, where you would not expect this particular stone which you are holding to get crushed and result in some residual stones or remnant stones left behind. So all the stone holding forceps are unlikely to have a ratchet, which is likely to cause trauma, and then you'll not be able to remove the stone intact. Any other instrument, a very common instrument where you don't find a ratchet? Your scissors. Does your scissors have a ratchet? So there are a lot of these instruments where you don't find a ratchet. So just move ahead. As I told you that I would like to probably discuss under these headings: cutting and dissecting, clamping and uploading, grasping and holding, and retracting and exposing. So I think you need to get familiar with these blades. I don't want to spend much time on this. And you've been doing surgery, and what type of blade you would like to prefer, and I would be very probably interested to know about this. Where exactly you use this 11 number blade? So please remember, this is something which is very sharp, and where you would probably use to drain an abscess by the conventional method. And for finer dissections like thyroid, I think this is the one which you would like to probably prefer, and rest of them are all used for probably giving skin incisions. You have a Bart Parker handle and you have these sizes, and these sizes basically you need to select a size which probably fits in the blade which is appropriate for that particular size. Scissors are many, and the conventional scissors or the straight scissors or curved scissors are called as the Mayo scissors. As you see, there's no ratchet here, and this is something called as a Metzenbaum scissors, which is little longer, and this is one which we often use actually. I don't know how many of you are using now. Are you using a blade or a heat suture cutting scissors? So I'm surprised, at least in my setup I see students using only a blade. But this would be ideal because this will enable you to properly remove those sutures. This is called as a heat suture cutting scissors. So grasping and holding a lot of things, and the common thing is a dissecting forceps. So what I just want you to probably answer is, these are called as a tooth and non-dissecting and non-tooth dissecting forceps. Unlike the instrument what I've shown where you have ratchet, finger bows, you don't have anything, you have just two blades, and the peculiarity of these particular instrument, you have serrations on the outer aspect. Because if you take an artery forceps, most of you might have seen these particular serrations which are confined to the blade, and they're mostly seen on the inner aspect. But this is the one where you have serrations. This is something which is very peculiar to this instrument, where you have these serrations outside. What is the purpose of these serrations? So this is basically for grasping, and where you try to hold this particular instrument using your thumb and index finger. So that's also called as a thumb forceps. And where is it used? Since the name suggests it's a dissecting forceps, it aids in dissection. So we have a tooth and non-tooth, and this non-tooth is also used for securing hemostasis. I'm sure that if the vessel is small and where you would just like to catch that and cauterize it, you would ask the sister to give a non-tooth forceps. You have tissue forceps of three types. One is called as a Bacchus, the second one is the Lace and the Alice. And you might be having some cockers because each institute have a different set of instruments. But please remember, they're all called as tissue holding forceps. Out of this, which is atraumatic and which are traumatic? Babcock's is traumatic or atraumatic? And the rest of them, Alice, Lane's, and Cockles, they're basically. Have you seen all this? So these are something which you would like to use to hold the tissues. So this is an Alice tissue holding forceps. I just would like to be fast, and you can see these particular serrations here, and obviously it is likely to cause a lot of trauma. Lane's is the one which I would like to prefer to use, particularly because there's a curvature of these particular blades and their fenestrations, and it will help you to probably hold that. And suppose I'm doing a lymph node dissection, it becomes very easy for me to hold the lymph node. So this is the place where I would like to use Lane's tissue holding forceps, and this is the Cockles clamp, and again a traumatic clamp. Then we have a sponge holder. The peculiarity of this, it has long handles. I just want you to appreciate this long handles. And the reason why you have to have a long handle is, you need to be away from the area where you are trying to probably clean. If you would have had a very short handle, then it would be difficult for you to just clean that area. So this is called as a Rampley's swab or a sponge holding forceps. Would you like to use only to just clean the operative site, or would you like to use this instrument elsewhere? Gallbladder, where you would like to hold the infundibulum of the gallbladder. Where else you would like to use? Have you seen vagotomy being done? So, off late, I think we have not been seeing a lot of vagotomies. Yes, that's one place where I would like to probably search the posterior vagus using this. Anywhere else you would like to use? So this is called as a Rampley's swab.
Sir, any obstacle use, obstacle gynec use?
Sorry for my... In the examiner would like to ask a lot of usages. Sometimes it gets so exhausted that you don't get an answer. So I think try to probably remember few indications and few usages of this instrument. I think that would be sufficient. And this is a towel clip, and this is called as a Mayo's towel clip, and this is a Doyens. I think you're all familiar with this figure of 8, and I'm sure that you know where exactly you would like to use and what is the usage of these particular towel clips. And this is what I am very fascinated about. This is called as a Lister sinus forceps, and you see this particular tip is blunt, and there are some serrations on the inner aspect, particularly only in the distal part. And you don't have this. Why you don't have a ratchet for a sinus forceps? You all know that it's being used to drain an abscess, but what is that drainage called? What is that method which you like to? Hilton's method. So what's the difference between a conventional drainage of an abscess and a Hilton's method of a drainage of an abscess? Because this is where I catch, I'm honestly telling you, this is where I catch a student if I really want to trouble him. As you know that if I want to pass a student, I just ask his father's name. And if I want to fail him, I'll ask my father's name, because the student will never be able to guess. So it's become so easy, but I think this is not for examination or passing, but this is something which you need to know actually when you're practicing. So what is the Silton's method of drainage of an abscess? So you make an incision on the skin and the subcutaneous tissue, and then you would like to use this particular, thrust the instrument through the fascia, and try to open the instrument and rotate all across to break the loculi. That's something which is very important. And you're going to continue to do that till there is some bleeding. And after that, you just would like to pack it. But this packing is only for the next 24 hours. After that, never ever pack this abscess cavity. Because when you're trying to pack, you're not allowing the pus to drain out. So please remember that packing an abscess cavity in the initial 24 hours is purely for hemostasis. Because there's no other way by which you can achieve hemostasis. So please remember a favorite instrument of most of the examiners, which is called as a Lister sinus forceps. Needle holder, the peculiarity, I am sure that you have very, very short blades. Can you see this? And the uniqueness of this is they have some crisscross serrations and there is a groove in between. So these will prevent the needle from wobbling. So that's an advantage, and you need to know where exactly you need to cast the needle. You know where exactly you would like to cast the needle? Where exactly you would like to cast the needle? I'm sure that lateral 1/3 end. So this is where you would like to probably use, and the ratio between the blades and the handle is 4:1. Desjardins forceps, I am sure that you might have been using this on exploring the CBD and then trying to retrieve the stones from the CBD. And coming to the third one, clamping and occluding, I think a very common instrument that is artery forceps. So the name which is given for is a Spencer-Wells artery forceps. Is it curved or a straight? It's a curved. So I think most of you are also using this for hemostasis. Yes? So this is called as a Kelly's modification of Spencer-Wells artery forceps. So that particular instrument, that is a Kelly's hemostat, which you would like to use, exclusively should be used for achieving hemostasis. But I'm sure that most of you will be using this for dissection. Yes or no? So the Kelly's modification of Spencer-Wells artery forceps is some modification which has been made in this for securing the hemostasis. But I think we use this particular instrument for dissection purpose. And we have different shapes. We have of different lengths. They're also of different serrations. Something which is very unique and very popular among the examiner is mosquito. I'm sure that most of you might have used. It's very sharp, but you know why it's called as a mosquito straight or a curved artery forceps? There are a lot of reasons and there are funny answers which come, but you have any answer for that? Why it's called as a mosquito straight or a curved artery forceps? The blades, the tips of the blades are so sharp that they'll be able to hold the proboscis, which is one of the oral cavities of the mosquito. And some people say that when you try to apply this, it looks as if mosquito is basically sitting on the skin. The bite which results of this particular instrument, after applying this instrument, resembles the bite of a mosquito, but it is being derived from the name of a plane which was used in World War II. It's nothing to do with all this which has been told, but actually this instrument has been named after a plane which was used in World War II. I'm sure you have been using this. Where exactly you use this mosquito straight or curved? What is the surgery where you often use, where you would like to have some nice dissection using the sharp tip of this mosquito curved artery? Thyroid, yes. Appendix, which instrument you would like to use when you try to dissect the mesoappendix? Suppose if you have a thick mesoappendix, obviously, which one you would like to prefer? A Spencer-Wells curved artery forceps, or you would like to use a mosquito curved artery forceps? So basically, that's again a place where you can use this mosquito if you feel that the masonry is very thin, where you can just apply this instrument and try to isolate the appendicular artery. One thing about this large instruments, and particularly when you have applied the occlusion clamp, intestinal occlusion clamp, that part which has to be probably sacrificed, we apply some crushing clamps. Of late we don't get crushing clamps, and we would like to use this large straight artery forceps or a curved artery forceps onto the part which is being sacrificed. Why do you need to apply that? What will happen if you don't apply? You have applied the occlusion clamps, but you also would like to use this this particular crushing clamp. Why you would like to apply? So that to prevent the spillage of the contents of the bowel. And the one more place where you would like to use this crushing clamp is when you crush the base of the appendix. Which instrument you would like to use to crush the base of the appendix? Straight artery forceps. And the reason why you would like to use this, you just would like to occlude, but still the occlusion is not complete, so that's the reason why you just tie a ligature at the base of the appendix. Sir, how much time?
One minute, sorry interfering.
Sir, no problem.
There is one joke about mosquito forceps. What is the problem of using too many mosquito forceps during surgery? The answer was, patient is not post-operative malaria.
There's a likely chance that these instruments are so small, particularly when you're using an abdominal cavity, there's every chance that if you don't keep your instrument count correctly, there's a chance that you might miss this in the abdomen. Sir, how much time? 5 minutes?
Okay, sir, 5 minutes.
I'll just complete this. Sorry. So this is a Spencer-Wells. The medium-sized artery forceps, whether it's a straight or a curved, is called as a Spencer-Wells. The long ones are called as the Baileys, and the short ones are called as the mosquitoes. This is a message I want you to take back home, and this is a very simple instrument which you can pick up and identify. So this is, I don't know how many of you are using this, but we have stopped using this Lane's twin gastrojejunostomy clamp. We have become a little overconfident and then start probably doing this anastomosis without putting the clamp. But only thing is, if you have this particular instrument, set of instruments in your department, definitely they would like to ask, so this, which one should go to the stomach and which one need to go to the jejunum? The one with the screw S stands for stomach. So please remember that S and S. And usually there will be a ring to the jejunal clamp, and that probably is one of the features by which you can identify that this is the instrument where you would like to probably apply it to the jejunum. And a lot of complications using this. They say that likely to be, though they are called as occlusion clamps, there's likely to be some injury and trauma, and there can be some anastomotic ulcers. But one peculiar thing about all these occlusion clamps is, unlike the Spencer-Wells curved artery forceps, where you have transverse serrations, unlike the needle holder where you have crisscross serrations, this is a one which has longitudinal serrations. So please remember that this is a unique feature of an occlusion clamp. So retractors, I'm sure that we don't have finger bows and all that. It's basically a single stainless bead which is curved both proximally and distally. Where exactly you would like to use? Because though you might be using this quite often in the exam, and the examiner is asking where exactly you would like to use, and I don't see answers coming from the students. Where exactly you would like to use? Common emergency surgery where you would like to use? DU perforations, yes or no? Gallbladder surgery. So this curvature is something which is useful to retract the liver, because you know that when you are trying to apply some traction over the liver, it is likely to cause injury. So this curvature will help you to prevent injury to the liver. We try to put some mobs and then do that. This is a surface retractor and Langenbach's retractor where you have a handle and blade. You see the blades are very short and they're perpendicular. You have this Joel's thyroid. Again, we got away with this. We are not using this, but it's a self-retaining retractor. Examiners are fond of asking you what is that retractor, thyroid retractor which you would like to use. This is called as a Joel's thyroid retractor. This is a Balfour's abdominal wall retractor. The tubes are many. I think this is something very common tube, but please remember that your answer need to be, you can't just call it as a Riles tube. You need to call it as a Riles nasogastric tube. So most of the times it becomes easy for the student once he gives a complete answer. You should not allow the examiner to ask the next question. So please ensure that it is Riles nasogastric tube. I am sure that why it's called as a nasogastric tube, how to identify and what are the markings on this particular tube, and obviously the length. So these are something which you are expected to know. Cade's T tube, and I'm sure that the majority of you have used this, and definitely this is something which is commonly asked. Foley's self-retaining urinary catheter. Please again, you give a complete answer. Don't say it's a Foley's catheter. Please say that it's a Foley's self-retaining urinary catheter, and obviously what causes this self-retaining nature of the Foley's? You inflate the bulb. And what is it which you would like to use to inflate the bulb? Distilled water or saline? Distilled water. I'm glad that you. Would you like to use air to inflate the bulb? No or yes? What will happen if you use air? The most common problem is the balloon is going to float and it will not be able to drain. The other complications like air embolism and rupture and all that, but please remember that a balloon which is filled with air is likely to float. It is not going to sink. So that's a problem with this. And you have a two-way and a three-way. Malicots is something again a very common thing, and where else you would like to use other than the bladder? Liver abscess, yes or no? So this is again a common tube which you would like to use. This is again a confusing one. You might be seeing regularly in the theatre, and when you are asked to identify, people say it's a tracheostomy tube, but please remember this is a Gudel's airway. This is something which can save the life of a person. So it will probably prevent the tongue from falling backwards. I'm sure that most of your anesthetist friends will be using this during recovery. So this is called as a Gudel's airway. And please remember the cuffed and uncuffed. Uncuffed is the one which you would like to use in pediatrics, where you just would like to put some throat pack. So please remember this. And then you have a tracheostomy tube where you have an inner and outer tube. If you have a Portex one, then obviously at disposal you have only one tube. They'll ask you which is longer. Obviously the inner tube is longer when compared to the outer tube. The advantage is when the inner tube gets blocked, the outer tube still remains in the trachea. You just have to remove it and clean it. Latest tube is again something which you would like to use in paralytic ileus, and some people use it at this time. And there's again a confusion. Some examiners accept this as a proctoscope, and I would prefer to use as a Kelly's anal speculum, because the difference between these two is you have a light source for this particular instrument, if you would like to call it as a proctoscope. But a speculum is something which does not have a light source. So you need to probably know the parts of the instrument, and you need to know like how you would like to insert this. That's again something which is sutures. I think you're all familiar. Laparoscopic instruments, I think this picture speaks about everything, and the length is usually 33, and you have a shaft with insulation. People have been doing, you know that how important is basically the shaft is, and with an insulation, and you have an inner effect part, and you have different types of instrument, and the peculiarity of this is this 360 degree, which is not possible in a conventional surgical instrument, and obviously you have very long handles, and so different types of laparoscopic instruments, and you have various needle and suction apparatus, and this is a dissecting forceps. Yes, I think most of our institutes have this laparoscopic instrument, so you need to know. Examiners are fond of probably asking you questions related to this. Scissors, I think one thing I just would like to probably remember is, I think we all know that the instruments are made up of stainless steel, and it's an alloy of iron, nickel and chromium and all that. That's one thing they ask you. You have tubes which are made up of red rubber, and you have tubes which are made up of PVC. If you probably looked at the endotracheal tube, they're made up of, if you take a Rice tube, they're made up of PVC. So you need to identify like what is it made up of. The second thing is the sterilization part, which is very, very important. So would you like to go for sterilization or disinfection? So obviously I would like to prefer sterilization, because I can eradicate the spores also. And what's the commonest and the popular method of sterilization? So an autoclave. So they'll expect you to like what is the temperature and what is the pressure and how long you would like to use, what are the indications and contraindications. So a word about this disinfection and sterilization, which is very, very important as far as handling the instruments. And all those disposable tubes are either sterilized by ethylene oxide sterilization or gamma radiation. So this is in just about instruments. Sir, 5 minutes for specimens. I'll just complete the specimens. The other thing which very, very important is specimens, and each institute has different kinds of specimen. It's very unusual to find the common specimen in all institutes. So as such, I could also probably see some one specimen. I think most of the specimens what they have, we too have. Can you identify what this specimen is? Looking at the shape, the most important part of this session as far as specimens is concerned is you need to identify the specimen. Right? What is that organ which basically it resembles? Without that, I would not prefer to have a specimen. Pathology is secondary. First, I just need to know the anatomy. So what is that specimen you have here? What does it shape? What is the shape? So obviously it's a kidney. Are you able to see some lesion which is having a variegated appearance? So it's a specimen of kidney showing a lesion with a variegated appearance somewhere in the middle. And what does it probably suggest? It's a surgery which was done. What surgery was done? Nephrectomy. So what could be this lesion? So it could be a renal cell carcinoma. And what are the other names for renal cell carcinoma? You have Gravitt's tumor, internist tumor, and you know that there are some paraneoplastic syndromes which are associated with this. Yes or no? So examiners would like to know the definition of paraneoplastic syndrome and the features associated with renal cell carcinoma. So is it some old timers, they have the fancy of asking, is it an antemortem specimen or a postmortem specimen? Antemortem or a postmortem? Obviously, nephrectomy is done. Antemortem or postmortem? Antemortem. So then I think a very common condition in the foot, I don't think you need to worry about that. I have to identify the foot and there is a lesion with some blackish pigmentation. Obviously the answer is malignant melanoma. So all the discussion which can happen is around the malignant melanoma and how you would like to manage this. And the other lesion which you often come across, at least we have a specimen of squamous cell carcinoma, and here we have a malignant melanoma. Then the different types of malignant melanoma, and this is again a picture, and this is something which is very interesting, and I just want you to highlight the point that when you are being given a specimen, just don't look at from one side, just turn it around and then see all around to make sure what is that specimen. Without that, just don't be in a hurry to answer that. So that's something which is very important. Just don't look from the front. So you just have to rotate this. When you look at this, what do you think this could be? Colon or small intestine? Colon. So obviously it looked like to me as a cecum, but I was insisting I just would like to have an image, and then I probably looked at, where is that image? You have not loaded that? I thought you will load that. So when I looked around, then I could see the Tinea coli. That is how you need to identify a specimen. It's not a specimen of a small bowel. And if you want to tell that, how did you identify that? When you look around, then you will see the Tinea coli. That's a marker that it's basically a specimen of the large intestine. And I could see some appendix also. So probably it's a specimen of right hemicolectomy. Maybe if there would have been a small bit of small intestine, then things would have been much easy. So what is it showing? Obviously a malignancy. So questions will be related to probably how would you like to diagnose this and how would you like to manage and what is radical hemicolectomy. This is again, I think, a multinodular goiter. I tried to look around and I could see some multiple nodules in the thyroid, and it's a cut section, and then the image is not very clear, but this is where I could see some pathology and what type of malignancy you get in a multinodular goiter. So follicular carcinoma, maybe it's a follicular carcinoma, and they have done a total thyroidectomy. And this is a specimen of intersusception, and again, I didn't have a specimen in my hand. I'm probably suspecting that this could be a small bowel, and there could be some intersusception into because what is the most common type of intersusception? So probably there could be some lead point, and you need to define what is intersusceptum and intersusceptions and how you reduce this intersusception, because this is again, we have it, but it's very clear where the ileum is getting into the colon. So the most common is ileal or ileocolic? Colic. And this is the end, and sorry sir if you have taken a little more time, and I hope that I've done my job, because the time allotted was half an hour, and I just would like to wish all the postgraduates all the best, and I would like you to probably take one message home is, you're not here to pass exams. Please remember that examination is only a part of your life. What is important is knowledge and practice. So please, I feel very painful when I probably look at the examination orientation which postgraduates have. So it's not for examination purpose. It is for your knowledge and your skills which need to be improved, and which you need to probably transfer the skills and knowledge to the benefit of the common people. So thank you very much.
Excellent lecture by Dr. NVN Reddy sir.
NVN Reddy sir, very good session you have conducted. But for the sake of postgraduates, one instrument, what is that male cord scatter? How the flower is being made? They usually ask for the examination. How the flower is made? Flower of that male cord scatter. Please tell that one. And I'm very, my fancy instrument is Cocker's forceps. So all the postgraduates, what are all the things which go by name Cocker? Who is Cocker? What are all the things which go by Cocker? Who is Cocker's forceps? What else? What do you know? Cocker's incision, very good. Next. Cocker's chest. Next. Cockerization, very good. Next. Cocker's vein. What is that? Fourth vein of thyroid. What is Cocker's reflex? So these are the things which can be asked in the examination. Cocker's reflex. Anybody?
Cocker is a noble laureate also.
Cocker is a noble.
Sir, we'll go on to the next session. 5 minutes.
Cocker's reflex is on mild compression of testicles. There will be involuntary contraction of the anterior abdominal wall muscles. That is called as Cocker's reflex.
Sir, please sit down, sir. Just 5 minutes. Dr. Verma has come all the way from Hyderabad. This will be the last session, and most of you are answering very nicely. And thank Dr. NVN Reddy sir. It's an excellent lecture. Thank you very much, sir. Dr. Verma, please.
Good evening, everybody. I request all of your attention for next 5 minutes. Just I will give the broad overview of operative surgery. So it is important to prepare for all the components of examination, not only to pass the examination and also to which is very much useful in the clinical practice. And training sessions like this will definitely improve your overall knowledge and